Good morning, everyone, and welcome back to another installation of NB Heart Centre CV Weekly Rounds. This week, I'm excited to introduce Dr. Sam Wang, who joined us back in 2017, and much to Satish's excitement and delirium, he's been a great addition, and they form a nice 1-2 punch. And I think Sam has brought a lot of different expertises from his training over to us, and we're fortunate to have him. I thought it would be a good idea. It's always good to do a little refresher as far as the role of electrophysiology in the setting of heart failure. And with that in mind, I asked Sam to talk to this particular subject. So Sam, take it away and enlighten us as to the current status of pacing therapies in heart failure.
Okay, thank you, Answer. And thank you for arranging all these teaching sessions for us. I'll just begin. First, I have no disclosures on the subject. Answer asked about some ICD.
And do you want to maybe just blow up your screen so it's entire, fills the, like if you go down to the right-hand side all the way.
Okay.
Yeah.
Like that? How's that?
You got her. Thank you.
So Answer did ask me to just talk a little bit about ICD therapy briefly. ICD, while it's not really heart failure therapy, and more, in my mind, sudden cardiac death prevention, it dates all the way back to 1999 in terms of the guidelines. So I'll just go over the history. You could see how things have evolved gradually over time. We were in Canada the first to adopt the EF under 35%. The Americans started with the EF under 40. And that was based purely on the fact that although the trials that enrolled with EFs under 40 as a criteria, the majority of patients were EFs under 35. You could see where CRT started coming in. And at first, the indications for CRT were quite broad, with any Q restoration over 120. But you could see over time that they started adding more specific criteria to CRT based on data from CRT response rates. So as we progress, you could say we're getting more specific. Left bundles are extremely important. The majority of patients who respond are left bundles. Everything else is a fairly weak indication. And from the ICD side of things, we're also progressing towards the range where later implant is being considered. And there was an article just this year in CCS by Jeff Healy, wondering with current medical therapies if we should be considering at least 3 to 6 months of medical therapy before deciding on ICD implant. But currently the guidelines are still 1 month post revas and 3 months. So I'll just talk a little bit about the conduction system. This is some immunofluorescence. You could see the various conduction tissue. You could see also the aortic valve, so how closely related. So the surgeons will appreciate conduction block with TAVIs and surgical aortic valve replacements. We have the right bundle on the upper slide and the left bundle system on the lower slide. And I bring this up because there's a significant difference between his Purkinje conduction versus the muscle-to-muscle conduction that we get from our typical pacing. So obviously his Purkinje is fast for depolarization and muscle-to-muscle connection is slow. So we deal with when the conduction system breaks down, and the slide on the left, Microsoft picked it up for me. It looks like someone's having a coffee break. But when the conduction system runs into problems where, let's say, the right bundle blocks, you get the right bundle branch block pattern. And if the left bundle blocks, you get the left bundle branch block pattern. Now, in converse, you could say what is still working. In the right bundle, it's the left bundle that's working. And in the left bundle, it's the right bundle that's working. This is what we do in EP. We make topographic maps of conduction and tissue activation. So you could see on the left some right bundle patterns. The earliest activation is the areas which are red, and the latest areas of activation are the areas that are purple. And you can see how in right bundle, the left ventricle is activating first and the right ventricle is activating late. In contrast, with a left bundle branch block pattern, it's the right ventricle that's activating first and the left ventricle is activating slowly through muscle to muscle conduction. And that makes a big difference because as we all know, the left ventricle is probably the most important pumping chamber. So this is another way of doing a topographic kind of map. This is of a right bundle branch block. And you can see the earliest activation is in the right with the latest activation far lateral in the left ventricle. So when we do procedures like a CRT, the ideal spot is to put the lead in the latest activation, which would be a left lateral coronary sinus vein. So the wider the QRS, the more we can try to synchronize and get a better QRS. So this is just a rough idea of how we do it. This is a typical CRT system. We have a RV pacing lead, usually the ICD coil is there. We have a LV pacing lead, which goes in through the coronary sinus, and we try to find a small branch off the coronary sinus. The most optimal site is around the lateral. We sometimes use the posterior lateral as a second best and the anterior lateral as a third best. Generally, any anterior or a middle cardiac vein are poor because it's interventricular rather than lateral. And so you don't get the latest site of activation. And that's just going back to one of our previous topographic maps of activation. This is from our center, and this is just an example of RV pacing. You can see how wide the QRS is. Has a very typical RV apical appearance, superior axis kind of inverted in 2-3 AVF, and also has that very inverted pattern in V1 towards V6. You can see the QRS duration I put on the side, 180 milliseconds, which is pretty typical. You get a wide QRS, which means the majority of the conduction is muscle to muscle conduction. This is an example of fairly decent CRT. This is in the same patient with his LV pacing enabled. You could see with the extra pacing coming from the left lateral, we've now shortened that QRS duration with pacing to 144 milliseconds. So we use the analogy, it's like you go from a front wheel drive car to an all-wheel drive car. You're pacing from two different sites, hoping for better activation and a better squeeze from the ventricle. Now, there's something new we've been doing recently. It's still, there's been probably about 6 centers in Canada that have been kind of trained. I think more have been since January of last year. It's been out for probably about 10 years, but the technique has really, with sheaths and leads have really improved to some extent. It still has a very high learning curve, more so than typical CRT. And that's because we're plugging the pacemaker lead directly into that conduction system, which you saw at the very beginning with the immunofluorescence. And you can imagine we're trying to hit something that's really, the His bundle is really like 2-3 millimeters wide and probably about 5 millimeters to a centimeter long. So we're trying to aim and target and plug our lead directly into the conduction system. So these procedures for now take quite a bit longer. Some centers have gone it to a quicker point where it's almost as fast as a regular implant. But it typically takes about 100 procedures to develop good expertise in this. So we're still working on this. And so it's still a matter of a pretty big learning curve. The other thing that's been done is some researchers in China have been showing that you could plug it directly into the left bundle going through the septum. And that tends to be a little bit easier because the left bundle is a wider branching network. There's obviously some things you have to be careful of when you do that. So this is an example of what we call selective His pacing, where we've plugged it directly into the His conduction, and it looks almost like a narrow normal QRS. You wouldn't even be able to tell the difference. This is what we call a non-selective His pacer, where it almost looks like someone has a WPW because you have a little bit of muscle conduction just before it enters into the His Purkinje system. And you could also see just how narrow the QRSs are. This one's 134 milliseconds. The previous one was 79 milliseconds. So theoretically, even better than CRT. We've talked a little bit about why we synchronize, but here's just another view. Again, topographic map, orange and red being early activation and late activation being blue. So in the right bundle, the left ventricle activates late through muscle to muscle conduction. When we pace in the left ventricle, we are able to then depolarize that left ventricle a little bit earlier and kind of coalesce the two wave fronts from the right and left to get a better squeeze. We used to use dp by dt as an indication of how good or how powerful the squeeze is. But a lot of the echo indicators have been kind of so-so, so we don't really check anymore based on just echo criteria for a response. What our goal is to hopefully get some CRT responders. So this is an idea of what can happen. Typically, we have the typical heart failure patient. We would expect progressive heart failure and drop in EF over time. You have a small percentage that are what are called negative responders, which means they continue to get worse or get worse rapidly. You have non-responders, which again, continue to get worse. So there's some debate whether non-progressors are actually responders because you're changing the curve of heart failure. So if you have changed someone who's progressing rapidly to someone who has stabilized, is that considered CRT success and response? And then there's a small percentage of patients, usually we say about 1/3, who are responders, who have some improvement in EF. And now again, definition of responders is still a little bit controversial because some studies look at functional response, which means you have better exercise tolerance despite no change in EF. So some studies consider those responders, even though the EF doesn't change. And then we have this very small percentage that are super responders. And in my mind, a lot of them are non-ischemics. They tend to be women. I don't understand why, but the majority of them seem to be left bundle, non-ischemics, and women that tend to be the super responders. So this is where it gets a little bit tricky. Who should we synchronize? We get a lot of referrals, both for right bundles and left bundles. Obviously, left bundles, as seen earlier, has a higher indication because there's a higher response rate. So it's more of a class 1 indication. Right bundles are more, or non-left bundled QRSs are more of a class 2B. And this is the reason why. When you look at CRT response rates, we know that above 130, or even with the more recent studies, above 140 milliseconds with a left bundle seems to be where the response rate falls. Now, if you were to draw the curve over and extend it out to what a right bundle would be, you would expect the right bundle would have to be almost 200 or 220 milliseconds to have some response. The other thing you're thinking about is if you have a right bundle branch block, the left bundle is activating normally. So you're actually just trying to synchronize the RV pacing to catch up with the native QRS. So theoretically, just a DDD pacemaker with some tweaks in the timing could give you just as good synchronization as a CRT in a right bundle. So we've tried that a few times. I've even put in a right bundle pacemaker, meaning I'm pacing the right bundle to overcome the right bundle branch block and give someone a narrow QRS. But even in that patient, basically he had no difference in his exercise tolerance. So again, it's one of those things where how important is the right bundle or the right ventricle to someone's functional capacity. And we all know that obviously the left ventricle is probably the most important pumping chamber. This hasn't gone into the CCS guidelines yet, but it was talked about at our EP meetings, even as recently as kind of 2 years ago, when before COVID, in our CCS meeting in Montreal. And the thought was that we should be using a more stringent Strauss criteria for CRT response versus a typical classic ECG criteria for left bundle branch block. So you'll see sometimes Dr. Toll or myself may decline what apparently looks like a YQRS and kind of looks like a left bundle. Sometimes people have, let's say, a Q wave anteriorly that's prolonging their QRS, and they actually have fairly normal QRSs. Other times they may have like a left anterior fascicular block or a left posterior fascicular block, which still has a very similar access to a left bundle branch block, but doesn't have that notching. And because they are activating in the left ventricle, an extra LV pacing lead may not always benefit these folks. So again, the thought is, should we be using a more stringent criteria for left bundle branch blocks? And this is just some more. This is a slide on the left bundle branch. I found this a nice slide from Duke, so I borrowed it. But again, just shows what the Strauss criteria is and what we tend to look for. And obviously, if we have a typical wide left bundle with notching, that would be the ideal candidate for the typical CRT with LV pacing. The right bundle branch blocks I kind of talked about, can we resynchronize them? So theoretically, what you need to do to synchronize these right bundles is pace at the site of latest activation. And that's two particular sites. Either you're pacing on the RV free wall, because that's the most lateral site in the RV. The drawback is if you're putting an active fixed lead there, number one, how stable is it? And number two, you have a much higher rate of perforations in that area. A lot of our patients are low EF, frail little 70, 80-year-olds, and their RVs are quite thin. Typically, even the perforation rates at the RV apex are fairly high. And I've had one frail 70-plus-year-old kind of end-stage heart failure who had a perforation and died as a result. So I'm very careful in terms of RV pacing placement. With them, they tend to do better either with passive leads or with fixation on the septal wall, none of which are great sites for RV synchronization. Another site that Satish uses quite a bit is the RV outflow tract, which I have very little experience of, but that's also a potential site of late activation that you could pace from that could help with right bundle branch blocks. So I thought I would just end with some examples. Obviously, the simple ones are pretty simple, but we get referred patients for various reasons. This was one example I thought is good to think through. This guy had an ischemic cardiomyopathy. He had severe MR with a narrow QRS. He developed VT, and then his EF dropped to 25%. He then we did a VT ablation to solve his VT, which was a slow VT that was persistent. And that resulted in resolution of the VT, but then he became persistently RV paced from his defibrillator. And his EF had improved post-ablation to 35% again. But he was still short of breath. And the question was, could we improve his MR with CRT? So I don't know if these tend to, but my thinking when I saw this patient was this: if he had severe MR with a narrow QRS prior to this, our CRT never gets even close to that narrow QRS. At most, we get to kind of 130, sometimes if we're lucky, 120 milliseconds. So likely his MR would be worse than it had been with his narrow QRS. So the answer is, for that is no, we don't expect the MR to improve in that situation, even with CRT. It may improve from his current situation. He might have some symptomatic benefit, but I would still expect his MR to be severe and probably slightly more severe than when he had a narrow QRS. Other tricky situations which we may not have the best answer to is, for example, we had one that was a young person with a rate-related left bundle. So what do you do for them? Because they're usually at rest, they have a narrow QRS, but when they go above a certain heart rate, they develop a left bundle. Do you synchronize just for that? And will that synchronization actually help improve their EF and exercise tolerance? It's hard to know. On the other hand, a lot of these patients do progress in that their rate-related left bundle develops and progresses to a full left bundle at a lower resting heart rate. So we've done here both early CRT implants, and sometimes we take a watch and wait approach. And it just depends on the patient because we're trying to balance infection risk. So if the patient is per se, let's say a sarcoid on immunosuppression, you might want to see how they do on immunosuppression for those, let's say, first few years, and then decide on upgrading to a CRT down the road. So that's one way of dealing with that. But a lot of times we're trying to balance the risk of the device versus the potential benefit. And same thing with, let's say you have a left anterior fascicular block, but it's wide. Some of the new devices have fusion algorithms that try to fuse a pace QRS with the native QRS. So do you try to position the lead more in the left posterior region, or sorry, the left anterior region, because you have a left anterior fascicular block, and try to fuse that LV pacing with his left posterior that's intact to try to get the QRS more narrow? Or do you just wait till he has a full left bundle and try to put it in the most optimal site when he has a full left bundle, right? So there's a lot of in-betweens that we don't necessarily have a good answer to and we don't know if this will improve their response rates. But depending on the patient, we might give it a try, especially if they're severely symptomatic and have poor quality of life. And then obviously hemodialysis, open wounds, sepsis, the balance is they're very sick, so they likely will have a high chance of benefit from CRT. On the other hand, they also have a high chance of complications. So when they have dementia or they got to twiddle and dislodge their leads, and we're going to have to keep going in to replace and reposition the LV lead, are we going to get infections because they have open wounds and sores in the hemodialysis? And then we're going to have to extract the device in 1 or 2 years because of infections that seed to the device. So a lot of this is talking to the family, talking to the patient, and trying to figure out what makes the most sense for that particular patient. So having kind of talked about that, I just thought, ended up with the thought that, medicine is a bit of an art. We do have guidelines. Brent Mitchell always told me as a guideline writer that guidelines are just guidelines. But once you learn the guidelines, then it's a bit of an art to figure out what makes the most sense for the patient that's in front of you. So I'll just end with that and see if anyone has any questions or anything they want to talk about.
It's fantastic. Thanks, Sam. That was great and a great overview. I felt like that was kind of like CRT for idiots, and I'm right there at the top of the line. So appreciate that. If anybody has any questions, feel free to either unmute yourself or pop it in the chat. I just wanted to ask one quick question from a surgical perspective. This is clearly no longer your dad's CRT, like this is more complex. And once upon a time, if we would take a person to the OR with low EF and a left bundle, one of the inclinations was to offer up an LV epicardial lead in the lateral wall and then fire that through the chest wall and put it into the pocket so that then you could do an easier, CRT type system. But it seems to me like it's more than just putting it somewhere in the LV lateral wall. I mean, you're mapping out territories that you feel will have the highest degree of success. There's if you want to optimize your success with CRT, you need to know more than just, that you're going to be pacing an RV and an LV in synchronicity, right?
That's correct. There's a lot of different measures. The one measure that a lot of people use now is the QLV. So in the native left bundle branch block pattern, how late is your sensing on that LV lead behind the start of the QRS? So in some patients, the sensing almost looks like I'm sensing in the ST segment. That's how late I am. And when I see that, I know that I'm actually going to get pretty good synchronization. It tends to be, again, a very lateral branch and tends to be more basal and apical. But when I see something that's very late, you know, that you're going to get fairly good synchronization. Whether that results in response is hard to know because every patient's different. But at least you're going to make a big improvement to the QRS duration.
Okay, a couple of questions in the chat box. Thank you. First of all, cost, data on quality adjusted life years. How often do you see an improvement in functional MR with CRT? So like, bang, 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 fire them off because Michelle's got a question afterwards.
Yeah, cost is a little bit tricky because obviously age plays a big factor. And when we start implanting in folks with older age, like even in ICD and those above the age of 80, there's really no cost benefit. But we have been doing it. But not all provinces do. And so sometimes there's an age restriction on ICDs and CRTs in some provinces because of that reason, based on evidence. So I don't want to really talk about that because I can sound a little bit ageist in doing that. But I just want to say it's controversial. And then in terms of functional MR with CRT, there have been improvements. Usually it's about 1 grade. So if you're severe, you could get into the moderate range with response. Super response is very rare where someone goes from an EF of, let's say, 25% back to like almost normal. We've seen it a few times, but like they tend to be, like I said, non-ischemics, wide left bundles, and for whatever reason, they recover completely. And in those cases, it can be extremely dramatic, but that's extremely rare. So usually I would say, if we're lucky, we may improve it 1 functional grade from, let's say, severe to moderate or moderate to mild.
Sounds like the MitraClip. Oh, just kidding. Okay. All right. And then his pacing, his bundle pacing. And I really feel like we're hearing more and more about this. And from your standpoint, who do you pick for that? And then more importantly, what is your routine for follow-up? Any tricks on that front?
So we've been trying to do as much of the his pacing follow-up as we could here in St. John, not always though. And just because at least the first follow-up is tricky, and the most common problem with his bundle pacing is, number one, when you're in that middle of the learning curve, there's a high rate of his lead dislodgements. And we've certainly seen that at our center. The other thing is that a lot of times, if people don't know that it's a his pacer, they think that the his lead is, or the RV lead is dislodged, because you see a pacing spike and you see a stretch of a flat isoelectric segment before the QRS starts. So it almost looks like the pacing spike is not attached to the ventricle. And so those ones tend to be a little bit trickier. And I try to emphasize when we're discharging to a different center that they have a selective his pace. The non-selectives, which you saw with that look a little bit pre-excited, those are a little bit easier to deal with because it's almost like dealing with a regular pacemaker. You just have to look a little bit more carefully on the ECG to see that it is activating, has that little pre-excitation. But those ones are a little bit easier to manage because it is plugged more kind of half into the muscle before it enters into the electrical system. So from the trick perspective, that's a little bit easier to deal with than the selective his pacing. And follow-up, I mean, we're still learning. They say a lot of the larger centers, like in Chicago, where they do it all the time, they have stretched it out to the regular pacemaker follow-ups, 6 months to a year. We initially see them sometimes 1 month, 6 months, and we may see them a few more times just to be sure until they get kind of a year out. But afterwards, you would feel that it's had time to stabilize and scar, and it should just be similar to management of a regular pacemaker.
Wonderful. Sam, thank you so much for taking the time, for changing your schedule to suit our schedule, and for enlightening us on this subject. Obviously, your guys' role in improving the outcomes of patients in New Brunswick is vital, and we're super glad that we have both of you and hopefully a third at some point down the road joining us. So congratulations, well done, and once again, thanks so much. Next week, there will be no rounds, as there is a concurrent research presentation that's being done in Halifax by members of our department. But we will pick up back on the 28th of April when JF and Chris will speak to the VAD program and the concept of that program in New Brunswick and rolling it out. Everyone, have a great day.